Welcome. Good morning, good afternoon, good evening. Today's CCAE dialogue focuses on engaging healthcare professionals to champion HPV vaccination. My name is Meenu Anand. I have the honor to serve as the Director of Global Cancer Prevention and Screening at the American Cancer Society and the co-chair of Cervical Cancer Action for Elimination, CCAE, along with the colleagues from Cancer Research UK. Many of you may be familiar with our CCAE dialogue series, which we have been running for past few years and will continue into the coming year. These virtual dialogues are designed as spaces for organizations and individuals to come together, connecting with peers and experts in meaningful, critical conversations. Today's dialogue series focuses on a critical enabler of HPV vaccination uptake in communities, healthcare professionals, and their role as HPV vaccination champions. Across countries and contexts, we know that a strong recommendation from a trusted physician, nurse, or a healthcare extension worker is one of the most powerful drivers of parental decisions to vaccinate. Yet, engaging and equipping healthcare professionals to take on this role consistently requires substantial effort. Our presenters today will share with us their efforts to support, motivate, and partner with physicians through various channels so that they can champion HPV vaccination in their clinics and communities. Next slide, please. As you can see, we have a packed agenda for you today. We will start by getting to know each other, then hear from practitioners from 3 different countries, regions, who have engaged healthcare professionals through medical societies, Rotary, and virtual training. You will have the opportunity to dig deeper into one of these projects of your liking in the breakout session. Next slide, please. A few housekeeping items before we get started. Let's take a minute to rename ourselves in Zoom so we can more easily identify each other and make connections when we move into the small group discussion. There are 2 ways to do this, as shown on the slide. One, you may open the participant list, click More next to your name, and then select Rename, or right-click on your video title and choose Rename. Rename yourself with your name and add your organization if applicable. I'll give a minute to everybody. As you continue to do that, we also request active engagement in this dialogue. I know our speakers would love to hear your thoughts, comments, and questions. You can participate in various ways today. 1, use question answer features to add questions for the presenters. 2, in small groups discussion, raise your virtual hand within Zoom to come off mute and share reflections. And finally, when possible, have your video turned on in the small group discussions. Note that we will record the main session and share with you later. Next slide, please. Please take a note of the upcoming dialogues this year. Next slide, please. You can access recordings of all our previous dialogues on our website and YouTube page. Summary reports of these discussions are now being shared in the chat if you have missed them in the past. Next slide, please. Lastly, I would like to share an update on the CCAE learning series on HPV vaccination, which you may have heard of. We have released a summary report on the learning series sprint from 2025, which you can access in the chat. This series provided 6 small grants to CSOs globally And as you see, four are engaging healthcare providers and extension workers in some capacity. This includes the Rotary Club of Al Tahrir, Egypt, who we have the pleasure to hear from today. And with that, next slide, thank you. With that, let's start with a quick speed networking event so we can get to know each other. You will be automatically placed in a breakout room with four other attendees that are randomly selected. Once you are in the room, please introduce yourself to each other and begin with the question on the slide. There will be no moderator in the room. Please share your name, organization, country, and if time allows, one thing that you are excited about your work on cervical cancer prevention. I think.
So I just opened all rooms. Everyone is automatically assigned, but you will have to select, you just basically have to press yes on your screen to joining the room.
Thank you, Leo.
Yeah, no problem.
Leah, for anyone who's just joining right now, do they get automatically put in a?
No, I have been assigning people.
Okay.
Do you think it's better to not join at this point? It's only been
No,
like,
that's fine. I just didn't know if I needed to help do anything or if.
no, thank you.
Yep. Hopefully the others tell them what they're. Oh, I guess I should put it back to speed now. That way.
Hi, those who have just joined. We have just broken out for a couple minutes to do some speed networking. So you may not be in a group. So just bear with us for about 2 more minutes and then we'll get back to our regular programming.
I think Leah's putting them in a group so they can, if there's still time,
Okay.
they can introduce themselves.
Yeah, maybe anyone who joins from this point on, I won't because it's like
Okay.
a half minute.
Yeah, it'll get too short. Great.
I think we'll have to just keep making that announcement though, so nobody knows that.
Mm-hmm.
We let people in the waiting room or keep them there until we.
I'll just announce when I'm admitting people.
Okay.
Hi, everyone who just joined us. We are currently have everyone else in breakout rooms, but there's only about a minute left, so we're just gonna ask you to wait right here for now until everyone rejoins this main room.
And I see, Leah, there's like 20 seconds left. Is that right?
Yes.
Okay, so they'll be back soon.
Yeah.
Okay, I'll go ahead and not touch anything. So, and for anybody who's, yes, listening, we'll have everyone join back and we'll start with our first presentation.
Perfect. All right, I'm gonna close the breakout rooms and bring everyone back to the main room right now.
Welcome back. We hope you were able to meet with some new colleagues. Let's now hear from leaders and practitioners from around the world about how they have engaged and inspired healthcare providers to promote HPV vaccination. Today's presenters have long and illustrious career. In the interest of time, I will introduce them briefly. Their full bios are being shared in the chat. Our first two speakers are Ms. Sutapa Biswas and Dr. Digant Shastri, who will share their work engaging physicians through medical societies in India. Ms. Biswas is the co-founder and executive director of Cancer Foundation of India and has championed community-level action on tobacco-related cancers, cervical and breast cancer, and HPV vaccination for over 2 decades. Dr. Shastri is a senior consultant pediatrician and CEO at Kilol Children's Hospital, NICU, and Vaccination Center. Dr. Shastri has had several prominent leadership roles, including serving on the Government of India's National Technical Advisory Group on Immunization and as past president of the Indian Academy of Pediatrics when CFI initiated its efforts. With that, over to you, Sutapa.
Thank you, Meenu. Thank you. And it's an honor for me to share this space with Dr. Shastri, with whom I started this work, and and to Meenu and the entire team of ACS for this whole work working together. Thank you. Well, India, I'll just give you a background that when we started this work, we did not have the HPV vaccination being rolled out by the government. So at that point of time, the coverage was low, which was way back in 2019 when we initiated. But now government has partially started that work. So things are a little different now, but we were preparing the country for the rollout. Next slide, please. And what we saw that, when even though the vaccine was available in India from 2008, we found that it was not being recommended. There was hardly any uptake. And that was the whole idea of working. And we embarked on the research, next, on the research to find out what exactly was being done. So once we did that, I'll just give, this is the brief of what we did, that, once the problem was identified, then the research was conducted to understand exactly what the barriers were, followed by developing an action guide. And then we went into the training in 2 phases, of different kind of physicians. Next. So what we saw in India is that, during the research, when we reached out to physicians around the country in different parts, we did see that, there was issues that we initially did not understand because, the physicians we thought were recommending as much. But, when we worked on this, we realized, next please, we realized that through this entire process, that it was affecting parental decision when the physicians weren't recommending the vaccine the way we thought. And they had specific barriers, and that's what we addressed as we moved on. And if you would see on these slides that there were issues related to the subject and the clarity on what the vaccine was and all its safety, efficacy, all these issues were actually the barriers for the physicians who are not recommending enough. Next. So as we moved, we found that, as part of the study, that there are clearly three groups of physicians we need to target to start with, but the pediatricians, the gynecologists, and the general practitioners. And the whole idea for us was to tell them that, what was the burden like for cervical cancer and what is it that they can do in preventing and creating, of course, more and more champions on HPV vaccination. Next. So as we started, the first step, as I said, was developing an action guide. And the best part is that, we took the medical societies along, it was co-developed by all of them. So during that process, there was a lot of discussions, and that I think was the best part of it, that they were already introduced even before the training. They were introduced into what was coming, and which I think made the leadership very confident of what they were getting into. Next. That's how we started, actually. And the reason why we chose, when we thought of the physicians, we decided on working with the medical societies. If those of you who know India, it's a huge country, as we say, many countries in one country, varied languages, there are a lot of leadership around different states in different ways. So it's extremely complex to send any message in one language, around the country. And we also found that these medical societies are collectives where you have scientific credibility. When they talk of something, there is within the professional network that makes a lot of sense to them. And in the government, within their fraternity, among the public, physicians are trusted voices, and these medical societies are a collective of physicians. And of course, as I said, the nationwide network they have, unlike, finding individual physicians around the country. And as we complete the program, we realize that, with the medical societies, we can leave a large cadre of informed physicians who can then take the work forward, because we couldn't be training all physicians around. Next. So we took the reference of these action guide, and that's how we started. We reached out to the national medical societies. We had a lot of medical societies in there where we had to screen them. We went through about 50 of them who we thought were the right ones, and then we narrowed it down to the three. Next. And this is where we came to that we started with the specialists in the first phase, which is the gynecologists through the Federation of Obstetric and Gynecological Societies of India, who have a large number of members, and the Indian Academy of Pediatrics, which was individual pediatricians who are members of this, about 40,000. And followed by the phase 2, we actually associated with the Indian Medical Association, which is the largest medical association with around 400,000 physician members, which are general and other specialties also. Next. So once we had selected, as I said, on phase 1 and phase 2, in the phase 1, what we have seen is that it was all over the country. So we divided them into zones. And here you see 4, but then finally we had to do 5 zones. We had one central zone as well. And it was standardized messaging for all the zones and ensuring that the message goes to every zone of the country. As I said, since India is it's a huge population here. And in that standardized messaging, we had trained faculty who would deliver the lectures. We included role plays, and post-training was the biggest challenge for us, that, what do you do after training? So the monthly prompts were sent to them, and they were made to report as to what they were doing after the training, so that we know exactly how they were using it, the learning that they have had. And then we, as part of all this, we had selected members of the society to train them in a cascading manner, that we have a set of core trainers who were from the leadership, followed by master trainers, again, from within the society. They would train the members from around the country. And then, of course, physician champions would report the activities back to us. Next. So that was the phase 1 for us. It worked well. You can see the numbers. It was all done within a span of, a little more than a year. And these are specialists. So we had the 16,000 that you see, these are gynecologists and pediatricians. And they were all done through virtual trainings, a few in-person trainings, which they had organized at their end. Next. So this went on, and we had made sure that everybody gets a certificate. So it was all automated, so that after a point, once the training was over, and they would spend at least 70 to 80% time within the training. It was not just by logging in that we'd get the certificate. So they would then give it the certificate at the end of it. Next. So in phase 2, what we did was those who were trained in phase 1, they were used as the trainers. So from there, we had selected a few, and they were the national HPV faculty, and they trained the general physicians of the Indian Medical Association, the other third association that we worked with. And we completed about 31,000 trainings over a period of a year. And we ensured that they would move not only in the main cities, but to the smaller cities and towns, so that we are able to cover more and more in the fringe areas, not on the main city as much. Next. So this is how the trainings were done, and we continue to engage with them even now. Next. So there was evaluation that, did they learn whatever we wanted them to learn? And we did find that they did champion, they did continue to work on it. I won't say all, but many of them, which is a good number. And if we can keep them connected with us, and, if they can keep them engaged over a period of time, I believe they'll be able to take the message forward. And with the government now supporting it, I think it's going to be a little easier for us. Next. So they were all celebrated, and awards were given to those who have been faculty and who are champions. Basically, they are the most motivated. Next. So I'll just quickly go through 2 slides where, while selecting, when we started, as I said, the first thing was, of course, bringing them together, that, co-creating, making the research participatory in the initial phases, which I think had set the tone for the engagement in the future. If you complete the work and then you engage with them, sometimes, it may not work as much. Identifying the right medical society, because it was very important that since we are going to work with them and through them, it was important that we identify the one which has a common goal. We made sure that all of them, all the 3 that we work with, had the same guideline on HPV vaccination. That was the first thing that we checked, that if they're aligned or not. Medical society leadership needed to invest themselves. They would be the person to mobilize the members, because we would not know the members. So it is very important that you have a leadership who was very much interested in the subject. Of course, post training, as I said, was the monthly prompts worked well. And we could actually see the challenges they were facing. What successes were fine, but what is it the challenges were? We had to continue monitoring. Of course, we made a lot of changes as we went through the year. And as I said, for member champions, celebration worked really, really well. Next. Challenges, of course, each of these societies have the different kind of a structure. So it is very important for us to understand how they function. And that is how we could tweak, the engagement with them. And one of the challenges we had, which really hit us hard, was a change in leadership, because these societies have annual change in the leadership. So not all of them prioritize HPV vaccination. So it went slow at several times. So that was one of the challenges. Physicians were not always very inclined towards academic learning as they were working. Virtual trainings were not very exciting for many, because here in India, they have an interest in physical meetings. And of course, at that point of time, the government delay, there was a flip-flop going on, and that was one of the reasons why we had issues with the physician confidence. But then now I believe that will be a little easier with the government rolling it out. I think that's that. So we have these resources available for the physicians to access, which is one way for them to stay connected, and they can download these resources that are available on this site. Next. We rate in different languages also. So thank you so much.
Thank you, Sutapa. What an exciting body of work. You highlighted medical society leadership as a key success factor, and we now have one of the leaders with us that you started the engagement with. So let me now invite Dr. Shastri into the conversation. Welcome, Dr. Shastri. You were the Indian Academy of Pediatric president at the time CFI started this effort. I would love to ask you a couple of questions. Let me start out with what motivated you as the medical society leader to prioritize HPV vaccination for the membership?
Yeah, so thank you, Minu. At the outset, I thank the American Cancer Society as well as the organizers for having me on this platform and sharing our experience. The question which you asked about what motivated, the story started somewhere in the month of August 2019 while I was a president and naturally national president, remaining quite busy. But when I received an email from Sutapa regarding this project, uh, I expressed our readiness and to have a discussion on it. Because our schedules were not matching, we had a first meeting on the Mumbai airport. And in fact, because of the meeting, I missed my next flight. But I am happy that even though I missed that next flight, but we could do some good work. We could initiate good thing. So the discussion started in 2019, and as you know, or maybe some of you might be knowing, some of you might not be knowing, the Indian Academy of Pediatrics is the world's second largest pediatric society, having more than 50,000 members. Now, this society, the mission statement, if you see, the mission statement, it is to strive for the optimum growth, development, and child health, irrespective of the background of these children. And this mission statement we achieve through four pillar of activities. The first is professional education to the pediatricians. The name itself, Indian Academy of Pediatrics. So it is an academy. It's not a association which fight for the rights of the pediatrician, but it is an association which strive for the education of the pediatrician. So we have been regularly conducting various type of continuing medical educations activities, and in that one of the main what you call our typicality is that by and large till the COVID time it was a physical meetings, education during the physical CMEs. Of course, during the COVID time, the online learning started, but somehow it has not been picked up that well. So that is the first pillar is the professional education. The second pillar is about the advocacy and support. So for any child health related issues, we are the advocates. The third pillar on which we are working is a public awareness. Now, public awareness here is not just the parents, but it is the community as well as in the media and even making recommendations to the government also. And last but not least, we are having a role of consultancy and collaboration. So if you see the we are part of NITAG in India for the immunization policies. Our Indian Academy of Pediatrics is having advisory committee on vaccines and immunization practices, and our representation is there in the NITAG. Also, in a past, the Indian Academy of Pediatrics has participated in several collaborative programs. Like for the polio eradication, we had joined hands with the government and a global polio eradication initiative, this thing committee for pulse polio and all other activities. Similarly, in past we had a MR campaign. So for MR campaign also the Indian Academy of Pediatrics played a very important role. So with this background, naturally it is a duty of a organization, and as a president of this body, it was my mission to do whatever best we can do for the children of our country. That was a background. Now, as over and above this, you all will agree that cervical cancer, though it presents in the adulthood, but by and large, it has its seeds in the childhood. The infections during the early adolescent age or young age will have a presentation in the late in the adulthood. Plus, country like India has a high load of cervical cancer. Unfortunately, we have a high mortality as well as morbidity due to uh, cervical cancer. In fact, I feel sorry to say, but India is one of the probably capital for cervical cancer incidences. We have a very good vaccine available, and luckily, contrary to the other vaccines, this vaccine was made available for the Indian population right when it was available globally. For other vaccines, the story was that it is like a PCV or other vaccine, it is used in Western countries, then for after 6 months or after a year, this vaccine is available in India. While this vaccine was right available when it was globally launched. But this vaccine was not taken up very well. There were many factors because in the government sector, in the public hospitals, we have a large cohort of children who are coming. So, for the government, providing such a large cohort free of cost was not that time possible. At the same time, those children who are coming to the private doctors for the immunization, the cost was the factor because they had to pay from their pocket. Immunization is not covered in insurance in India. So, for both these reasons, this vaccine was not taken up very well. There were some myths also associated with this vaccine. People had some misconceptions also, and the doctors themselves also were not very much convinced about the utility of the vaccine. So, for all this reason, though a very effective, very safe vaccine was there, but it was underutilized in those days. Also, as a pediatrician, we are the first contact person with the patient, with the child. And again, we are involved with activities like school health activities, going to the schools for the seminars and conducting sessions for the children, conducting sessions for the teachers, parents. So naturally, we have a better rapport and better credibility amongst the community. So considering all these things, I thought as a president, if we can go ahead with this partnership and initiate the thing in my country, it will be beneficial to the our children and to the nation. So with this aim, we started the discussions, but unfortunately, then the COVID came, and because of the COVID, everything was on standstill. And then there were change in the leaderships, and naturally the leaderships had their own priorities, their own working preferences. So because of all these things, we could not take it immediately, but I am happy that by 2023 we could launch this activity, and almost 101 online workshops we could conduct.
Yeah.
And what Sutapa demonstrated in her presentation, we had online sessions, and the core group was there. Later on, there were resource persons, TOT work is conducted, and later on, providers programs were conducted online. So, though we could not reach to the projected number, there were several reasons for this. but still something we could initiate from 2019 to 2023.
Absolutely. Thank you so much, Dr. Shastri. Thank you for your leadership. We look forward to asking you more questions during the Q&A session. Now, I would like to invite Dr. Amal El-Sisi. Dr. El-Sisi is a professor of pediatrics, consultant pediatric cardiology at the Cairo University, and has been a Rotarian since 2002. Pardon me. She has served as the president of Rotary Club Al Tahrir and board member and VP of the International Rotarian Fellowship of Health Professionals, IRFHP. Dr. El-Sisi is a CCA Learning Series participant and a grant awardee. Over to you, Dr. El-Sisi, to share your experience with engaging healthcare providers through Rotary.
Thank you very much for the introduction. I'm going to share my screen. Can you see my screen? Yes.
Yeah, we can see it.
Okay, so I'm going to talk about our Rotary program of scale project United to End Cervical Cancer in Egypt, and how we plan to use healthcare professionals as champions of this program. The background and the UECCE program is a $2 million award to improve the health of girls and women in Egypt by reducing the incidence and mortality of cervical cancer and HPV infection through screening 16,000 women, immunization 32,000 girls, public awareness program reaching millions of Egyptians, and initially it was sensitivity training for specialized doctors and data collection and analysis. This was achieved through an initiative called Himaya, which is the Arabic word for protection, in collaboration with the Presidential Initiative of Early Detection of Cancer and the Ministry of Health and Ministry of Social Solidarity. The program works over Greater Cairo, which is a very densely populated area, includes Cairo, Giza, and Al Ubaid, which are the three directorates or governorates forming the Greater Cairo. What were the barriers and gaps in HPV vaccination uptake? There were a lot of barriers. The uptake was in the schools was very low. It was averaging 10.6%, and some schools refused totally. We have 7 schools that zero uptake. No matter what awareness we did, the parents refused totally. Not a single parent in 7 schools refused to give this vaccine to their girls. And the difference between the school and community was noticed. In the community, it was 53%, and in the schools, it was 10.3% only. So we investigated the refusal for the vaccine, and we found out as a summary, we did a lot of surveys, but in summary, there was lack of knowledge in 48%. There was misinformation and safety concerns in 21%. There was lack of doctor recommendation. In fact, some of the public, they noted that some doctors actually advise against the vaccine, and that was 20%. And there are some other factors like cultural, religious, and moral beliefs. So there is an important role for physicians in increasing HPV vaccination uptake. So we did a lot of surveys also among doctors from different whether private or governmental practice, whether junior or more than 10 years, specialties, different specialties, mainly pediatricians and gynecologists. And we found that 54.3% are not aware of the latest HPV guidelines or the WHO recommendation, and their knowledge is very vague and not clear. They were unsure about the public health concern of HPV or the cervical cancer problem in Egypt. They don't know the prevalence. So it was a major finding in our surveys that doctors really, and those doctors were chosen random. And you can see also from the specific knowledge that their answers are equal, which means they are not sure of any answer. For example, the age of screening, the prevalence, the number of cases, the mode of transmission. It means that it's usually this type of results indicates that it's a guess rather than a clear knowledge. So what did we do about it? What did we think we should do in the intervention strategy and solutions implemented to address identified barriers? We did a strategy shift. When we applied, or our initial assumption was that doctors are aware of the HPV vaccination, and the uptake is mainly due to lack of national program and the funding and budget problem. We came to the conclusion that that is not the problem. The problem is the real lack of knowledge among doctors and among public, and the misinformation. So although we continue doing sensitivity training for specialized doctors and nurses, i.e. training the doctors on colposcopy, on nurses on sampling and things like that, which are carried by the Ministry of Health in collaboration with the Ministry of Health, but also we needed to address healthcare professional in general, not only the specialized, but mainly the family doctors, the junior doctors, even the last year students, the house officers. They need to know about this problem. They need to advise their patients. They need to be aware of the importance of HPV vaccination and cervical cancer elimination. This is just an example of the sensitivity, where a small number of doctors are trained on colposcopy on simulators, and the large number that we are now addressing to attend different specialties, and also talk about different problems, different burden of HPV, not only cervical cancer, but dermatology burden, other cancer affecting males and females, genital warts, affecting infants with neonatal and infantile recurrent papillomatosis. So there is a big problem that not only cervical cancer, to make sure that the doctors are aware of all the basic information. So that we had done some progress, but we need to do much more in the future. The partnership is very important in these trainings in general. Partnership with the government, of course, the Ministry of Health, and as to do the sensitivity training, and also to train the general doctors in the hospitals. The private sectors, mainly MSD, because they sponsored a lot of the meetings. Scientific bodies like the universities and the societies, the pediatric society and the gynecology and the oncology and the colposcopy societies, they are all scientific societies, have a lot of consultants and leaders, key doctors in these specialities. And of course, lately we partnered with the Egyptian Medical Syndicate, which has a huge number of doctors and have a very active website. Over 100,000 doctors are associated with the Egyptian Medical Syndicate. Also, we targeting, as I mentioned, all doctors, all specialties, especially junior doctors, nurses as well, basic training as well as specialized training. Surveys are very important because it gives us a lot of information, especially before and after, and we adapt our training to the needs or the results of the survey. Curriculum development and curriculum adaptation and improvement. We also benefited a lot from the training that we had with the CCAE, focusing on the communication strategies for clinician and informing the clinician how to communicate with the patients, because this is also was a problem, and also in India it was a problem, similar culture. They have to be non-judgmental. They speak about HPV as a normal or as a disease like any disease, address the misconception, be powerful and affirmative in the message. A lot of communication strategies that we included in our curriculum and training. And also addressing the stigma. We have to be frank about that. We don't hide. We have to face that this disease or this vaccine is associated with a stigma in our culture, in our country, and we have to face that. In collaboration with partners to date, we did sensitivity training on colposcopy for doctors and nurses, and basic training and communication and data collection training. Also, the MSD did a lot of conferences for dermatologists, pediatricians, gynecologists, oncologists, but these are specific to these specialities, not as the general as we are aiming at the moment. This is example of our school vaccination, which was the first in the country. However, the uptake was low, yet it is still a success. I consider it a success because we could start this as a model for the government when they start the national program. Hopefully, they can do the same in the schools, and they can learn from our experience or from our pilot. The lessons learned, we have improved the uptake when we change the sites from schools to youth, and also it will improve further with doctors training and knowledge gap, filling the knowledge gap. We should continue the workshop for sensitivity training and also the general training and the stigma management. We should provide the doctors. We started already with the leaflets and the material. And also very important part, of course, are the nurses, social leaders, and health visitors. Very important part that should be not omitted. These are our total program results till February 2026. We are very proud Rotarians because a lot of this work is done by volunteers. Many clubs are engaged with us, and district leaders, and of course the Rotary Foundation, who gave us this generous grant, and we are very grateful to all the grants that we can get to improve, to reach the cervical cancer elimination goal, which is a worldwide goal. Thank you.
Thank you, Dr. LCC. Wow, is so many important nuggets. I hope we will get a chance to talk some more. I know our participants probably have a lot of questions, so please keep putting your questions in the Q&A. Get your questions ready for the Q&A session. Thanks again. Our final presenter for the session today is Dr. Jessica Khan. Dr. Khan is a professor of pediatrics and Dr. Ernest Baden Chair in Head and Neck Pathology at the Albert Einstein College of Medicine, where she also serves as a Senior Associate Dean for Clinical and Translational Research and as Director of the Block Institute for Clinical and Translational Research. Dr. Khan is Chair of the HPV Vaccination Subcommittee at the International Pediatric Association. Over to you, Dr. Khan, to share the program that the International Pediatric Association has created to train and engage healthcare professionals through its member societies in over 140 countries.
Thank you, Minu. It is such a privilege to be here today with these distinguished speakers and all of you who are participants, and a real delight for me to introduce you to the HPV Vax digital course and resources. Next slide, please. So this is a collaboration between the International Pediatric Association and the American Cancer Society. And again, it's called HPV Vax, Vaccinate Adolescents Against HPV Cancers. Next slide, please. So I'll give you first a quick overview of the course and then the resources available through the IPA. So this is the landing page on the International Pediatric Association website, and there's a very quick and easy way to register for the course. You can see the registration button in the middle of the slide, and on the right there's a QR code for registration. People register for this course through the IPA's learning management system, and once they register, the login credentials are sent to their registered email address. Next slide, please. So a bit of information about the course. This is a free online training and resources for healthcare providers anywhere in the world. It provides up-to-date scientific information about HPV-related cancers, and also HPV vaccination. There's a focus on practical strategies for communicating with families of adolescents. And the website also provides ready-to-use tools and resources for real-world settings, and I'll show you some examples of those in just a moment. The training is self-paced. We estimate that it takes about 4 hours to complete all of the 7 modules, and everyone who completes the series receives a certificate for completion. The training is currently available in English, but we are translating this webinar series into Spanish and French, and those will be coming soon. Next slide, please. So this is the course outline. Module 1 focuses on the burden of HPV-related cancers globally. Module 2 focuses on primary prevention through HPV vaccination. Module 3 focuses on how to make effective HPV vaccine recommendations. Module 4 focuses on answering parental questions and addressing vaccine hesitancy. Module 5 focuses on the cervical cancer burden globally, and also how we can implement a global elimination strategy for cervical cancer. Module 6 focuses on training healthcare provider champions in your community to increase uptake of HPV vaccines. And finally, Module 7 includes information about how to activate your medical society and your community around HPV vaccination. And very soon we'll have an 8th module on single-dose HPV vaccination. Next slide. So accompanying these webinars is an action guide for cancer prevention through HPV vaccination, and this is geared towards medical societies and other community organizations. And this is just a very brief overview of the action guide, and I'd encourage everyone to go into the website and explore this action guide. It contains a great deal of very helpful, practical, actionable information. There's a section on HPV cancer statistics and facts to get everyone up to speed on HPV vaccination as a prevention strategy for cervical cancer and other HPV-related cancers. There's a list of actions that medical societies can take to promote HPV vaccination, and some of those are alerting physicians and other clinicians about their importance in preventing HPV-related cancers, cultivating community champions and medical society champions, and then how to recognize and share successes in terms of promotion of HPV vaccination. And then there is a section on resources, and we have provided a broad variety of resources. Next slide, please. There's also an accompanying action plan template if you are part of a medical society that is implementing HPV vax. And in this action plan, you can define your goals, and then you can track progress towards those goals over time. Next slide, please. These are some of the ready-to-use resources that are part of the resource toolkit. So there's a frequently asked questions from parents section to answer the most frequently raised questions by adolescents and their parents. There are handouts for parents, and there are posters that you can put up in your clinic, and these are all tailored for different countries and regions and different cultural contexts. So you can choose for example, the poster, the handout that's most relevant for your region. Next slide. These are some testimonials from individuals who have completed the course. One of them is for a health officer in Nigeria, Aisha Kabir, who says that the HPV Vax online course was insightful, practical, and relevant to strengthening HPV vaccine implementation strategies, and the sessions enhanced my understanding of demand generation, community engagement, and effective coordination for HPV vaccine delivery in Nigeria. And there's another testimonial from Dr. Reem Atwan in Saudi Arabia, who noted that successfully completing the course was an exceptionally valuable and intellectually enriching experience, and that the program delivered high-quality, evidence-based learning that strengthened her knowledge of HPV prevention, vaccine advocacy, and public health strategies. So we've had some very positive feedback, and we are looking forward also to your feedback on the program and how it impacted your ability to improve HPV vaccination. So we really want to hear from you. So if you implement this in your medical societies, if you take the course yourself, we would love to know what you think about the course, and also if you use the guide, how you're using the guide. And we do have an online form that you can use to delineate what actions you're taking in your community or your country. And we would love to hear about your successes. And also we'd love to have not only your stories, but also your photos. Next slide. So, of course, we all know that with our effective and collective action, we can be the generation that ends cervical cancer and other HPV-related cancers. So we hope that you will register for the course, give us feedback. We hope that you will take advantage of the resources for your own individual practices and also for your medical societies. And I would be absolutely delighted to answer any other questions about this IPA HCS resource. Thank you very much.
Thank you, Dr. Khan, and really appreciate your delivery and sharing with us the course. And thank you to all the presenters. We are going to adapt slightly and stay together as one group for a moderated discussion. So we will now have, if we can have all the presenters back in one group, and we will hold a Q&A session. This is a great opportunity to hear directly across experiences from India, Egypt, and the IPA training platform. We really would like for you to engage, ask questions. We are a smallish group, so please raise your hand and we can come off mute and ask the question directly. You can say who the question is directed towards and ask your question. I know the presenters would love to hear from you. I'm sure everybody is tired of listening to my voice. But I'm going to ask my production team here to please help me. I cannot see hands raised. So if you can please tell me if a hand is raised and stop me. That way the presenter can ask the question. Or I'm sorry, the participant can ask a question. But let me start with a few until we have a question. So let me start with you, Dr. El-Sisi. What are you seeing right now in terms of healthcare provider perception of the HPV vaccine, and how has it shifted over time?
Of course, there is a shift in healthcare professional, but it's not enough. We are a very big country. We are 120 million. We have deep-rooted beliefs that hinder these beliefs hinder the uptake of the vaccine and give misinformation about this vaccine. So it needs a lot to work, but definitely there is change. Also one of the obstacles or the challenges or the barriers is that the vaccine is not yet in the national program. Although the Ministry of Health on its website encourage this vaccine, but it doesn't pay for it yet. So that's a big barrier. I am sure, like the India experience, the vaccine was there from 2008, since it started all over the world. But also there is a shift and there's a much more improvement when the government provided it, roll it into the national program. So we have to continue working. I am sure there is definitely shift. I can see it in my colleagues that they shifted their opinion, but we have to continue working. It's a lot of work because we have a lot of doctors and we are a big country.
Thank you. Thank you.
And Minu, we do have an audience question from Lucy. So Lucy, feel free to come off mute.
Thank you, Nina.
Thank you so much. My question goes to Dr. Amal, and just out of curiosity, how comes we had higher coverage through community outreach as compared to the school outreach? Was it consent issues? Just wondering, because in other countries we found that school-based outreach gets more girls at once. Of course, we have some challenges like school health collaboration and consent, just to mention but a few. But I'm just curious how you are able to get the girls from the community as compared to more girls from the community as compared to the schools. Thanks.
Yes, that's a good question. Bear in mind, this is a pilot project. It's not a rollout school through the national program. We have to get, because it's a pilot project, we have to get consent. When there is a school program in other countries, there is no consent. It is actually the opposite. Those who do not want to take the vaccine are the ones who should write a refusal form. It is usually when it's rolled by the government, any vaccine in Egypt at least, and in many countries, if it is part of the national program, we don't need consent. It's recommended and it just goes automatic. Now, when we are in school, we don't have the parents. So the parents know nothing about this vaccine. They have the teacher, we have the teachers, we have the social workers in the school, we have the girls themselves who take the material, the leaflets and the consent to their parents at home, who refuse because who ask their doctors, the doctors tell them don't take it. They didn't attend the awareness themselves. While in the community and in the youth center, we have the parents especially the mothers, mainly with the girls. So the mothers in the community will come to the mobile clinic to have the early detection screening test and will bring her daughter as well at the same time and will sign the consent at the same time. So that's why it is all goes back to lack of knowledge and misinformation and the lack of guideline or recommendation by the doctor. So if the parents already have the knowledge, don't have the misinformation, have the enforcement of their own doctor, the school uptake will definitely increase. And also because it's not in the national program. So although the Ministry of Health are the implementing partner and they are the ones who are giving the vaccine in the school with us, yet it is not yet it all goes to lack of knowledge. All of it is because of lack of knowledge, and we have to do it over years because the vaccine in Egypt it was there in 2008, nobody took it. So the company stopped providing it until 2020, 2021, when they started talking about this vaccine again. So very recent. Thank you.
Thank you, Dr. El-Sisi. Over to you, Dr. Shastri. Go ahead.
Yeah, so I just wanted to share regarding our experience of rolling out of HPV in the national immunization schedule in the February 2026. And what Dr. Amal said, because in past when there were vaccination activities carried out under MR campaign or vaccination activity conducted for the TD vaccine or Tdap vaccine in the schools, at that time there were certain issues of say there were some not serious adverse reactions, but there were syncops and all, and then it was highlighted on the social medias and people in fact got discouraged. So this time the government of India took a call to start the HPV vaccination program, but at the healthcare facility only. The schools are used for sensitization as well as the information dissemination platform. But the vaccination activities is carried out at the healthcare facilities, that is the urban health centers or the prime community health centers. And yeah, and of course, over the period, the many myths related to the vaccines has been cleared. So there was initially the experience was that there was some resistance or a not exactly resistance but a cool response. But over the few months period, it has been picked up well.
Thanks, Dr. Shastri. Dr. Mal?
Yes, I also forgot to mention that the misconception about infertility related to this vaccine is very strong, although it is false, and that puts also people off. So it takes time. I mean, the India experience is very exciting to me. I always admire the India experience, even in pediatric cardiology. So we are following suit. It takes time. The awareness and change of knowledge, change of attitude, change of beliefs, change of culture. And that's what we learned also in the learning session. It takes time, but we will get there.
Thank you. Thank you, Dr. LCC. Agreed. Let me bring you in, Dr. Khan. What have you seen that works to motivate physicians or medical societies to move from awareness to actively championing the HPV vaccination?
Thanks for the question, Minu. So the question is, what motivates medical societies to move towards action? Yeah, I think that medical societies are in a wonderful position to promote HPV vaccination because they have a cadre of members who they can reach, and the members trust the medical societies, which is very important. And in fact, medical societies are one of the most trusted sources of information for clinicians. And they have reach and access through listservs and through their meetings and so on. And also often with medical societies, there are regional and local sub committees of the medical societies. So they have reach into suburban areas, rural areas, and so on. Also, I think one of the things that helps motivate medical societies to helps motivate members of medical societies to move towards action, in addition to trusting their medical society, is the opportunity to receive education through the medical society and to receive recognition for their efforts. And so medical societies, I think, can help motivate not just through educational activities, but also through recognizing, for example, during the providing an award for members or for a local group of the society for moving forward with improving HPV vaccination. And they can they could potentially include some funding, small amount of funding for individuals to promote HPV vaccination, and they can bring people together. They can bring people together virtually, or they can bring people together during their annual meeting to connect individuals. And the last thing I'll say is that medical societies often are well connected with other civil service organizations, with other non-governmental organizations. Many medical professional societies have connections with other medical professional societies. A pediatric association might have a connection with an obstetrics and gynecologic professional society, for example, and can make those connections to help the medical societies learn from each other and motivate their members.
So true, so true. Thank you. Let me ask you just a quick follow-up question. You shared the training. Are the training and resources, first of all, only for physicians? And is there any cost to individuals or societies to use the materials and the training?
Well, thank you for those questions. The materials are not only for physicians, they are for clinicians, they're for healthcare providers. So they're not geared towards physicians, they're really geared towards a broad spectrum of healthcare providers and clinicians. And the course itself and the materials are all entirely free.
Thank you. Thank you. Thank you, Jessica. Appreciate it. Let me quickly ask if there is a follow-up question anywhere. I see a follow-up question, Dr. Shastri. Do the health facilities operate during weekends, assuming that the girls are in school during weekdays?
So exactly not all full weekend, but Saturdays the vaccination activities are continued. Sunday is a holiday at all the
Okay.
urban health centers as well as at the community health centers. So not holiday, but they carry out only emergency work. So, but these vaccinations are scheduled like on a appointment base. So the children are offered the vaccine as per their school timings. Say, suppose it is a afternoon school, then the children are offered the vaccine in the morning hours, because this urban health centers and community health centers, they start working by 8 o'clock in the morning. Similarly, if it is a morning school, then in the evening session, the vaccination is offered. So it has been taken care that no child miss the opportunity of vaccination.
Makes sense. And I think what you're raising is a point around the availability of healthcare, the vaccine or vaccinations could affect the uptake as well. So I think just definitely uptake has a lot to do with information, but at the end of the day, delivery of the vaccination also has some component that would affect the uptake, and that is the ease of access and availability during the time when a parent is available to take the child to get her vaccinated, him or her vaccinated. Is there any other question? Let me ask my team. Is there any other question from participant that I'm missing?
Sorry.
Please.
I'm terribly sorry. I'm on a different device and I can't find the hand up thing.
No, not to worry, Marianne, over to you.
Thank you very much. Something that I'm a gynecologist. I've been based in Scotland, the UK, for a long time. And I have seen the introduction of HPV vaccination and also had a lot of discussions as time went on. And the thing that struck me was that stories of success really influenced my colleagues. We had, for example, not only in Scotland, where we've had enormous success, but Scotland has a close relationship with Malawi, where they are also experiencing a great deal of success with supported by their governments, which of course is an absolutely vital thing to make your life an awful lot easier as it goes through. So I wondered if other people had found that.
I will ask any presenter to comment.
Well, I'll just come in briefly to what Anne said. In India, currently it is in a campaign mode. It has not been rolled out for all 9 to 14 girls. So what the government is trying to see how well this whole structure works, and also if there's resistance that is coming from the community at any level, so that when you have a rollout after a point, in a couple of years, when all 9 to 14 girls would be covered and continued. And another thing that they started was a single dose. The initial plan was to do 2 doses, and then the single dose makes it a lot more easier, again, because you don't have a follow-up. So when the government starts endorsing a single dose and a campaign mode, and also a lot of social media promotion through the government machinery, when you have the directors of all the medical institutions of the government giving out messages, which I think makes it way more acceptable to people, which we did not have until, as Dr. Shastri said, 28th of February, when you have the Prime Minister of India being there when the first girl is being vaccinated, which is being beamed live. So at least, that part of it, if you see the mainstream media in India also is extremely positive, and they keep on giving news constantly because the government of India machinery is making sure that positive messages are going. But at the same time, you have the smaller outfits of anti-vaccine messaging going on, which are through the WhatsApp, which are unregulated. So which are difficult because these are mainly going in regional languages, which makes it difficult again, but very, very convincing for local people to take a decision that, if they would want to take the vaccine. So these are the challenges that we are facing at the moment. Let's see how it goes, They'll be able to iron it out. And the government endorsement definitely makes a huge difference.
May I ask a second question?
Please.
Right. In India, is the government, if you like, able to control all India, or will there be some states that will be much more resistant to bringing in the vaccination and the campaign, if you see what I mean?
Some would be, but at the moment, the government has great control around the country. And since the central government is going to provide all the vaccines for free from one point, so definitely the procurement is a huge issue. Initially was because states had to purchase their own vaccines, but currently no. And also the way the different states operate, at the moment, the government has great control. And I think that most of them would actually vaccinate.
Dr.
Right,
Shastri, you had something to say?
Yeah, so I will just like to add, being a pediatrician as well as being a person active with both the academic body as well as part of NITEC. So let me tell you that the immunization program in India is very strong program. Though we have a huge population, we have so many diversity in form of language, in form of education, in form of socio-economic differences, religious differences, but still over last 15 years time the immunization has taken up very well.
Yeah.
The all the primary immunization vaccines, even the vaccines like PCV, Rota, these all vaccines are also available free of cost to the people who are going to the public sector. In fact, over last 5 years, we as a private doctors, we have observed a reverse trend that in the earlier years we had many patients who were coming to us for the vaccines, but now they go to the government facility for the vaccines.
That's
And
great.
they come for the consultation for the medical services, curative services to us. So yeah, the government immunization program is working very well. There may be some areas where there may be little less uptake. Like now, if you have a state like Tamil Nadu, state like Kerala, where they are on top in all the health parameters. Like they have a single digit neutral mortality.
Right.
And then you have a state like Bihar or Uttar Pradesh where you have a health parameters are little low compared to these states.
Yeah.
But overall, if you ask, the uptake is excellent. The
Thank you.
DPT-3 uptake is more than 90%.
Yeah.
Measles vaccination more than 90%. So
Yeah.
it's doing fantastic.
Great. Thank you, Dr. Shastri. Let me bring in some more participant questions here. Dr. Zafar, let me ask, have you up mute and ask a question. Good to see you, Nuri.
Thank you very much. Same here. Thank you for this wonderful session. I was just very interested. Congratulations, Sutapa and everyone else for a successful launch of the vaccine in India, and Dr. Shastri as well. I just wanted to know, WhatsApp, TikTok, all these social media things which are not regulated by the governments. How has the experience been in India? Because we suffered a lot because of these unregulated small, one person can just put up ye bada bura hai, this is so bad, this is so bad, don't have it, there'll be infertility and there'll be this and that, and all the people in the villages and small towns, they go by that. I just wondered how the Indian experience was. Thank you very much. Thank you, Meenu.
Yeah, so again, the social media is having, it's a dual-edged sword. You can have a plus as well as minus effect of social media. And definitely here also, not just for the HPV vaccination, but for the MR campaign, we had a very huge negative rumors on the social media. Learning from that MR campaign experience, and again, in the beginning phase of HPV rollout, we had some issues, but we overcome it. Like we had positive videos from the leaders, from the doctors, stating that I have got my daughter vaccinated. Have you got your? My daughter is safe. She is not having any side effects. Similarly, there were videos from the recipients, the vaccination activity videos, as well as post vaccination. They had their testimonial that we are not having any problems. Then there were some social media influencer, so they were also involved in creating positive public opinion. So all these things has been done. Our medical associations also, the Pediatric Association, the Gynec Association, Indian Medical Association, they all also join hands in creating more public awareness as well as clearing the doubts as well as myths.
Yeah. Thank
But
you.
yeah, definitely there were incidences, and then there were few people like who had posted some negative remarks. Later on, they were convinced to post a positive remark also. But yes, social media is a big issue.
Agreed. Thank you, Dr. Shastri. I see Dr. LCC. Please go ahead.
Yes, quickly, I wanted to comment on the success story. It has to be more than one, not only one factor or one success story. So if, for example, in our program, we vaccinated 20,000 girls, we had no side effects, no complaints, that's a success story. When the government implementing partner coming with us, although it is not yet on the national program, that boost and the success story, because the government is endorsing it and it's endorsing it on its media. When the doctors recommend it in their practices in hospitals or in clinics, that's another success. So it's many factors, not only one factor, not only one success story. Thank you.
Thank you. Agreed, Dr. LCC. CC. So let me, I'm looking at time. We have time for, I guess, two more questions. I see one in the chat, and see, Vandana, your hand is up. Let me ask you to come off mute, Vandana, and ask your question.
Good evening, and I'm so honored to be here today with you all. And the entire talk has been so very informative for me. I would like to tell you that I belong to Rotary, and here I'm from District 3011 in India. And my husband is a cardiologist, renowned cardiologist, working with a very big hospitals rather, he's associated with. And we decided about 3 to 4 years back, we decided that we were going to go ahead and start off with cervical cancer vaccinations, on our own. And we started off, first was, spreading awareness, going across to parents, going to schools, convincing principals, teachers, parents, and then finally the ball started rolling. And after that, the main concern that came up was that we were funds. We did not have enough. So I went across to various, CSR groups and companies that were offering us CSRs. I went across to them, collected a lot of money, and then I went around all over India vaccinating children. And I've been told I've done the maximum in the country. That's what people have told me, but I really don't know if that is true or no. But we brought in a lot of CSR funds, and I'm still carrying on with it year to year. People give in the money, and me and my husband are just, traveling all over all the time, all over the country vaccinating children. So it's been really wonderful experience. And anyway, thank you so much for, it's wonderful to know, what all is going on all over the world also. And thanks a lot for having me
Thank
here.
you. I hope you saw all the claps and the accolades that people were sharing. So thank you for sharing your experience. Let me ask this question that is in the chat, and this is open to pretty much all our presenters. Given the overlapping risk of HPV and HIV among adolescents and young people in developing countries, is there a practical model for integrating HPV vaccination and screening into broader sexual and reproductive health programs, particularly for students and those living with HIV? Could such a program or could such an integrated approach be applied effectively? And it says, sorry, I mean dropout student and those who are hard to reach. I think we get the question. Let me invite all our speakers and even ask we have a lot of practitioners sitting in our participant pool. So if you have thoughts, ideas, please share. Go ahead,
Dr.
Jessica.
Khan has her hand raised, so I think she might want to answer.
Yes, go ahead.
I'm happy to start, and
Thank
then
you.
I'd love to hear from others also. I think this is a terrific strategy, and many of us in sexual and reproductive health fields and adolescent and young adult health fields have been working towards these integrated strategies. So making HPV related cancer prevention a part of routine sexual and reproductive health care should be a priority, whether that's in school health centers or university clinics or HIV clinics, PrEP clinics, and so on. So I think some of the strategies that have been used have been integrating the services using standing orders and same-day services. So when young people come in for visits, offering at the same visit HPV vaccination or catch-up vaccination, cervical cancer screening if it is warranted based on age, and also STI screening, contraception provision, pre-exposure prophylaxis for HIV, and so on. And the question was asked about sort of stratifying by population, which I think is really important. So for students or adolescents or young adults, school-based or campus-based services can be very effective, and some of the strategies that can help to get them in are, reminders and text-based reminders, recall, workflows, evening clinics, weekend clinics, and so on. For people living with HIV, of course, integrating HPV vaccination services and cervical screening services directly into the HIV primary care can be really effective. Yeah, I think those are some of the some suggestions I might have, but it's a wonderful strategy, and I'm happy to talk more or provide some resources to the individual who asked the question for models that are working well.
Thank you, Jessica. We would possibly take you on those resources and may be able to share with the participants. So thank you. Dr. El-Sisi, your comments.
Yes, in Egypt, we have 14,000 women diagnosed as HIV and receiving treatment with the Ministry of Health. It's not a big number. It's not. We all know that cervical cancer is 6 times and HPV infection 6 times more common in HIV positive. So the strategy is excellent. However, in our country, like starting HPV vaccination to associated with HIV infection can it's a double sword. Although it's helpful, yet on the other hand, it may add to the stigma to the vaccine, which we try to sell as anti-cancer vaccine, not necessarily an STD, especially in our culture. So just to be careful giving the message at the beginning of a program like in Egypt. Thank you.
Great. Dr. Khan, did you have a follow-up final thought on that?
No, I just need to lower my hand. Thank
No
you.
worries, no worries. Well, thank you so much. And again, thank you to all our wonderful speakers today. Thank you to all our participants. We will share the links to resources and the recording of the session through email to all registered participants. Don't forget to register for the next dialogue, which will be on August 4th, on the role of patient navigation in cervical cancer. The link for that dialogue has been added to the chat. Follow CCAE on LinkedIn and subscribe to our emails to be sure that you don't miss any of this year's dialogue. And lastly, please complete a short survey that will pop up as soon as you exit Zoom so we can ensure that these dialogues are most helpful for you in the future. Thank you again. And thanks again for joining. We look forward to engaging with each and every one of you again on August 4th. Until then, take care and be well.
Thank you. Thank you so much.